good scientists that led them to ask the question of well, what does it mean to be a surgeon scientist? And to answer that question, you need to gather data. So what I was really impressed about with these two is that they made a concerted effort to go and to meet a long list of surgeon scientists on campus to find out what, for those folks, they viewed as their path to their current careers. And they gathered more data on what kind of successes have been accomplished by being a surgeon scientist, what opportunities are available to surgeon scientists uniquely. And so all of us now get the luxury of learning from what they took away from all their research on this topic over time. And so with that, I want to thank them for their hard work and invite them up here to present.
Well, thank you, Rahul, for that introduction. I mean, indeed, the last 6 months have been extremely formative. And to say the least, things have been very exciting, inspiring, motivating, even a little funny. I mean, remember Dan, so Dan on the last day of his surgery clerkship was scrubbed in a case, and the surgeon turns to Dan and says, "Okay, David, you've worked with me for 2 weeks now. We've seen dozens of these cases. Today I want you to tell me how I should close. Which suture should I use?" So Dan nervously looks around the room and says, "Sir, maybe the blue ones?" Pin drop silence. Everybody turns to Dan, and the surgeon says, "David, my boy, if you wanted to take the day off and get some studying done, I wouldn't mind."
Hey, Divyansh, let's not get ahead of ourselves here. Just last week, you were working through some derivations and proofs on the whiteboard when a distinguished member of the faculty comes walking by, takes a peek, and mutters to himself, "Oh, how many times have I told Carol not to let freshmen use our departmental conference room?"
All right, well, fortunately for you all, today's Grand Rounds is not about our stories in many ways, but after all these experiences, we did what many people would do next, turn to the scientists' Google, which is PubMed. And so when you input surgeon scientist in PubMed, the hits you get are along the lines of this, the extinction of the surgeon scientist. And in fact, this is not the first hit that comes up. There's a laundry list. Dangerous cut, are surgeon scientists really dying? Is this a real problem? Who are surgeon scientists? Is this myth? Is this legend? Is this career path feasible? Is this complete nonsense? What a joke. Look across cultures, look across languages, article after article, just showing how, this is a real problem. And, all our planning for the future sessions, led by fearless leader Skip, have taught us that the next thing to do is look at NIH data. So that is what we did. And actually, the NIH data tells the similar story from a different angle. So if you look at the last 10 years, there is a steady decline in NIH funding to departments of surgeries. In 2006, about 3% of NIH funds went to departments of surgeries, which has reduced to just over 2%. What is even more worrisome is the fact that the number of basic science abstracts submitted at the American Surgical Congress has reduced in half, right? So maybe this is very sad and gloomy. But if you take a deep dig at the data, you actually realize that about 60% of the surgeon scientists engaged in basic science research were funded after submitting one grant application in 3 years. And actually that number rises to 92% if they submitted 5 or more grant applications. Right? So one obvious takeaway here is that persistence pays dividends. If this is what you want to do and you stick to it, it'll work out. So let's play a quick game of trivia in the next 2 minutes. There have been 9 Nobel Prize winning surgeon scientists, and I'll throw out a few hints and let's see who guesses the most. Winner gets an extra size of pepperoni pizza Maggie has promised. So let's get started. The first Nobel Prize winning surgeon scientist in 1909 was this gentleman, and his work studied an organ that is a real pain in the neck. Thyroid, of course, Emil Kocher. How about 1911? This gentleman. Okay, this one is a little high. So this was Gullstrand for his work on corrective lenses after cataract removal. What about 1912? This classy looking guy, also tough. This was Carroll for inventing the first perfusion pump. In 1914, this gentleman. All I can say about his discovery is not sure who would give a Nobel Prize to such a discovery. All he did was squirted some water in a patient's ear and found shifty eyes, nystagmus and giddiness, wrote that up as a report, and then subsequently described the vestibular system to earn his Nobel Prize. What about 1923? We turn to Google. Google says this was a sweet discovery. Insulin. Okay, so let's continue along. Guys, remember the pizza? Okay, 1949. Honestly, I'm not the most qualified person to describe his discoveries because brain and behavior was very rough for me. But, this was Walter Hess, who mapped regions of the midbrain and, described how they control various internal organs. What about 1956? The big hint here is that, guys like him, this is what happens when a urologist can go around sticking catheters up willy-nilly. Right? Because this was a urologist who actually discovered cardiac catheterization. 1966. This gentleman. That's right, extra slice of pizza. So, Charles Huggins for elucidating the hormonal basis of prostate cancer. What about 1990? This gentleman. Okay, so this was Joe Murray for the first successful human kidney transplant. And lastly and most importantly, 1993. By this time, most of us were born, I guess. So 1993. Come on guys. Okay, just kidding. This is when we were born. So for the rest of this talk, we'll focus on the more contemporary surgeon scientists and through a series of vignettes, show you how surgeons pursuing basic science still holds tremendous meaning. And we've identified 3 opportunities that the surgeon scientist is equipped with. And those are the ability to come up with new treatment paradigms, the fact that surgeons deal with unique clinical scenarios, and that their scope of practice deals with a specific set of patients that gives them a whole set of opportunities which will become clear through the rest of this talk. But if you take a step back, surgeon scientists, physician scientists, most clinicians pursuing research are actually driven by access to failures. And we found that this was a theme that was particularly true for the surgeon. Right? In many cases, when the patient comes to the operating room, he or she has failed many medical managements, and oftentimes the surgery is one of the last options left. Right? And in those cases, access to failures becomes a major driving force for new discoveries. With that in mind, let's jump to case 1. So case 1 deals with a 26-year-old woman with uterine factor infertility who comes to the clinic to discuss possible treatment options. So what are possible treatment options that you could offer her? Anyone? I heard some mumbling of surrogacy, right? So I think common options in such a situation would be along the lines of surrogacy or adoption. But this 26-year-old woman in 1998, named Angela, had a unique proposition. She told her gynecologist, "What if you transplant my mother's womb in me?" This suggestion took her care team completely by surprise. This is not something they had thought about previously. But actually, if you take a look at the scientific literature, uterus transplantation was first thought of in the 60s as far as we could tell. And in the 60s, the auto transplant of ovaries and uterus was fairly successful, as you can tell, based on these 6 happy, playful puppies. Based on a few years of investigation, the first human uterine transplant was attempted in 2000. Many would call this a remarkable achievement because this was the first time this procedure was attempted in humans. But a lot of people would also deem it as a failure. And the reason for that is that after 99 days, this uterus had to be removed because of a vascular event. Although in these 99 days, the patient had 2 regular menstrual cycles, the end goal of this uterus transplantation was not achieved, right? The case started out with uterine factor infertility, and so it's of no use if you cannot deliver a healthy baby. But this led to a whole series of questions, right? Was the immunosuppression not adequate? Or, think back to Virchow's triad. There was a vascular event. So what about the vascular homeostasis? Right? Whole host of basic translational and clinical questions which sent the surgeon scientist on a path, right? And it all started with access to failures, right? This first attempt did not work out. And so we turned to our favorite animals, the mice. And in 2002, it was demonstrated that a viable pregnancy could be achieved in mice. But for some reason, people felt that immunosuppression would be much more suited to pigs. So in 2005, we jumped to pigs and optimized the right immunosuppression. Subsequently, immunosuppression in pigs is one story, but rats is where the money is at. So in 2006, people determined optimum inflammatory control in rats. But rabbits are cute. They have beautiful blood vessels, and of course, vascular anastomosis are key. So proper vascular anastomoses were then also replicated in rabbits. But if you look at all of these animals, they're not anatomically similar to humans. What is anatomically similar is, as this picture shows, is sheep. Right? Of course, sheep are anatomically similar to humans, and so much of this process was then replicated in sheep. But we cannot leave out monkeys and chimps, otherwise they will feel bad. So in 2010, the complete process was simulated in baboons and macaques, and long-term follow-up showed that these animals were indeed able to deliver healthy babies with a transplanted uterus. Right? And this range of basic translational and clinical science projects were extremely critical to the success of the uterine transplant procedure. And based on all of this, the procedure was eventually developed and perfected. So using all of these animal models, people were able to figure out that what you really need is end-to-end anastomoses between the external iliac veins and the uterine veins and arteries, and what the optimum immunosuppression would be. So this figure, the left-hand side, or your guys's, I guess, yeah, your left-hand side shows a cervical biopsy just a few hours after uterine transplantation. And on the right, you have a cervical biopsy 30 days after the patient was put on low-dose corticosteroids and azathioprine. And as you can see, most of the lymphocytic infiltrate is completely gone. So good immunosuppression was achieved. But of course, the ultimate aim of this, remember, is curing the uterine factor infertility. But if you look at the gestational parameters in this transplanted uterus, they're very comparable to what a normal pregnancy would be like. And indeed, this process just a few years ago led to the first live birth after uterine transplantation. Right? So let's take a step back and really think about how we got here. There are more than 1.5 million women who suffer from uterine factor infertility. It is estimated that anywhere between 1 and 500 women of childbearing age actually suffer from this problem. So the need for this transplant procedure is compelling. Compared to a lot of other transplants, this procedure is not meant to be lifelong, right? This is not about life versus death. This is about quality of life issues. And as I showed you, it required a decade-long series of experiments to really figure out how this transplantation procedure would work in a human. Now that this procedure has been somewhat perfected, it poses new scientific questions. Because for the first time, we have a system with three-way immune interaction. You have the host, the growing baby, and the transplanted uterus. And this novel three-way immune interaction allows you to ask and answer questions that were not possible before. For instance, evolution of T-cell repertoire or natural killer cells, which are found to infiltrate these uteruses. This process, or this procedure, was also recently successfully done in the United States at Cleveland Clinic. And our guest speaker today, Dr. Porritt, is also spearheading similar efforts here at Penn. I hope this vignette really communicated to you that surgeon scientists have a unique opportunity to come up with new treatment paradigms because of their anatomical understanding and the kind of patients that they see. So with that, let's go to case 2. So case 2 takes us back to 1970s, right? So this is when Beatles just released Let It Be. This is when the New York Knicks won the NBA championship and the Apollo 13 mission to the moon failed. Amongst all of this chaos, local paramedics rescued a 3-year-old baby boy with severe burns covering 90% of the total body surface area. My first question to you is, what is his chance of surviving? Let's throw out numbers. What do you think? I see Dr. Hugh Roth showing a thumbs down. So you guys are pretty spot on. In 1970, the answer would make a lot of us cringe, right? It's a mere 5%. And just imagine, taking care of patients like these where 95% of your patients don't make it to 3 months. How could you not do something about it, right? It doesn't matter what profession or what field of medicine you're in. Today, that number has gone up tenfold. And, this transition over the last few decades, again, required major advances in our understanding of what the pathophysiology of burn trauma is and how many of those could be targeted or better cared for. So we start with 5% survival, and people realized that these burn patients require the least amount of crystalloid fluid to maintain organ perfusion. And I'm sure we are all familiar with our friend lactated ringers. Right? People then found out that these burn wounds get infected with Pseudomonas. Remember mod 1? And we now have good antibiotic treatment targeting Pseudomonas. Right? Next came the understanding that emergent debridement is extremely useful for these patients. And over the past 2 decades, major advances have been made in phototherapy and laser therapy that allows better wound healing in these patients. We also realized that these patients require better metabolic support regimens because at a baseline, they have higher resting energy expenditure. People also came to the understanding that because the burn injury can cause inhalation injury to the lungs, positive pressure ventilation can be used to combat that. And next, just in the past decade or so, people have come up with really cool biomimetic grafts and skin substitutes to minimize mean mass erosion and promote convalescence. We've also understood the prophylaxis and the pathophysiology underlying post-burn stress ulcers, which has also dramatically improved survival in these patients. And all of this roughly sums up to a 50% survival today. But actually, almost all of this work exclusively was not led by one surgeon or 2 or 3 surgeons, but a whole host of surgeons who devised the basic pathophysiology, really understood what was going on in terms of our resting energy expenditure and how we could use that knowledge to come up with better targeted therapies for these patients. And much of the credit for this goes to this gentleman, Basil Pruitt, who was the first person to really observe that there was something different about the metabolism of these burn patients. His art of observation led him to really identify the neurohormonal changes that make a patient hypermetabolic. And he proved that elevated metabolic rate is a true hallmark of burn injury. Your heart rate, liver size, resting energy expenditure, catecholamines, fatty acids, triglycerides, entire body gets ramped up. And with recent advances in genomics, people have really come to the understanding that this is a true genomic storm, right? Many of the known canonical pathways get upregulated and downregulated. And this knowledge is important because many of these targets are druggable. For instance, you can use beta blockers to reverse catabolism in selected patients. One that we are all familiar with on this campus is IL-6, right, which we know from CAR T-cell therapy, right? Whether you're a 10th year veteran in the program or a first year baby, everybody knows CAR T-cell therapy, right? And in the cytokine storm that follows CAR T-cell therapy, IL-6 is implicated, right? People also understood that in the burn patients who do relatively well, the innate and adaptive immune dysregulation is relatively short-lived, as opposed to those patients who have serious long-term adverse outcomes where the immune dysregulation is much more persistent. So let's say with all of this understanding, your 3-year-old patient can now live up to 6 months or even 12, 24, or 96 months after this trauma. But what then? Right? As you can see in this picture, this patient now faces the problems of severe hypertrophic scars. And hypertrophic scars are a problem because they cause limited joint mobility, anatomic deformity, pruritus, compression, and they cause major morbidity in these patients. Right? So although you could say we've made an advance, survival has gone up tenfold. In the long term, many of these patients still don't end up doing well. So I would argue that actually this is a failure in many ways. Yes, we've made slow progress over the past few decades, but these patients are still not doing that great. So now again, the team of surgeon scientists went a step further. And because of the access to tissues that is available to them by the virtue of being a surgeon, they found that these tissue samples have overabundant myofibroblasts. They found that these myofibroblasts upregulate TGF-beta, and with this knowledge, you can now target TGF-beta in a variety of ways, right? Be it neutralizing antibodies or indirect inhibitors or oligos, but many of these targets are still in phase 2 or phase 3 clinical trials. Some of them are showing promise, others are failing, right? So we cannot stop here, and surgeons did not. They went a step further and identified what the downstream targets of TGF-beta are that really drive collagen expression. And they found that a molecule BRD4 is one of the key players of this process. So what you see here is an siRNA knockout, which shows that even in the presence of TGF-beta, the collagen synthesis is decreased. And they've also identified that BRD4 acts as an epigenomic regulator, and that's the process by which it is upregulating collagen synthesis. Now, why does this matter, right? So we've understood that BRD4 upregulates profibrotic genes. This is true for our burn patient. But actually, this is true for fibrosis across liver, lungs, kidney, heart. So these targets have been shown to be similar across a whole host of organs. And so I hope this vignette conveyed to you that surgeon scientists, because of their scope of practice, the patients that they encounter with, have a unique opportunity to not only enhance their care, but also expand the scope of practice by going a step further, really adding to what is known about the pathophysiology of the conditions that they take care of.
So here we have our third case out of 6. So here we have a 26-year-old right-handed male with a history of epilepsy that has not been well controlled on medications. And so this male is referred to this neurosurgical clinic for consideration of a surgical option. Initial localization studies of the epileptogenic locus nailed it down to the left temporal lobe. However, given its proximity to very eloquent structures, it was decided that they needed to do more fine mapping with invasive measures. And so indeed, the patient was taken to the operating room and cortical surface electrodes were placed, and the patient was monitored for epileptic events. And the question I wanted to ask is, what opportunities for understanding human brain physiology is afforded by this clinical scenario? And indeed, there are many ways to measure the activity of the brain. We can do so non-invasively with techniques such as fMRI or EEG recordings, or do so invasively, like in the case where we have cortical surface electrodes or even deep brain electrodes. All of these different techniques, of course, have advantages and disadvantages. For example, fMRI gives us better spatial resolution but poor temporal resolution, whereas in contrast, EEG gives us fMRI gives us poor temporal resolution and better spatial resolution, and EEG gives us better temporal resolution but poor spatial resolution. Cortical surface electrodes gives us really good temporal and spatial resolution, so we can do very fine mapping. Now, to do this kind of research, we have to couple this with a clinical indication. And so for these cortical surface recordings, it's often coupled with the treatment of drug-resistant focal epilepsy. And the clinical indication here is to localize the epileptogenic focus, and research can be built on top of that. Similarly, for the deep brain, to target deep brain nuclei, this is often done in patients with Parkinson's disease or essential tremor. And in these patients, deep brain stimulation devices are used to suppress the motor symptoms, and research can be added on top of that. And because this research is done in an invasive way, we have to think about sort of the unique ethical considerations here.
And so I really like this way of defining two unique dimensions of ethical considerations. So on the x-axis, we have to think about the invasiveness of the measure used. Are we doing just recordings and collecting data, or are we stimulating the brain? Also, are we doing cortical surface recordings, or are we using penetrating electrodes? On the y-axis, we have to consider how far we are deviating from the clinical indication to perform research. And of course, on one end, we have no deviation at all and simply collecting data. On the other end, we have complete deviation doing invasive things for the sole purpose of research and of no clinical benefit. And I'd like to draw an analogy here between this and maybe some phase 1 clinical trials, where again, you're trying a drug on healthy patients who would not be expected to benefit from the drug, but you're still doing it for research purposes anyways. And I think what is unique about this situation is simply the invasiveness of the measure used. And so with this framework, I'd like to ask the question, how does the brain decode speech? How are you able to interpret everything you've experienced in the past 30 minutes? And so linguists have thought about this question for a very long time, and they have defined a phoneme, which is the smallest unit of sound that can compose words, that can construct sentences, and form speech. These phonemes, there are some 440-some phonemes in the English language, and these phonemes have been divided up into many different ways. We have our vowels and we have our consonants. Our vowels can be divided up into our monophthongs and diphthongs, and our consonants can be divided up into numerous different ways. And so this is Noam Chomsky's assignment of all these features, and we have features such as where in the mouth they're said, whether in the front, in the back, in a low position, in an anterior position. We have all the whether it's voiced or not voiced, and numerous other features. And the question I want to ask is, okay, this is great. This is done through a variety of perceptual studies and also thinking really hard about these issues, but is there a physiologic basis to all of this? And so indeed, the experimental setup is to simply expose patients with cortical electrodes planted on their surface to an auditory stimulus. And they found that these specific electrodes were activated specifically during speech as opposed to doing no sound or white sound. And in fact, when you expose them to a sentence, we're actually really exposing, we can deconstruct that sentence into a waveform. And so let's listen to this sentence.
And what eyes they were.
We can decompose this sentence into the waveform shown above, as well as into the individual phonemes that correlate with that. And then we can look at the neural signature of every single phoneme that is corresponding to the auditory stimulus. And if we do this, if we expose the patients to a barrage of the entire phoneme inventory of the English language, we can start constructing a map of how every sound in the English language is mapped to certain parts of the brain. And indeed, this was done. And so we have here on the x-axis from the left to the right all the different electrodes that were placed in the patient. And on the y-axis from the top to the bottom all the different phonemes in the English language. And we see that certain phonemes with similar features activate similar places in the brain. So if we look at the phonemes D, B, G, P, K, these phonemes activate a certain part of the brain that are not activated by certain other phonemes, such as the vowels in the middle and some of the other phonemes here on the bottom. And so this establishes a neurophysiologic basis for how speech is decoded by the brain. I'd like to take this one step further and say, okay, well, speech is more than just the words we say, but it's also how we say it. And so the question is, how is intonation and prosody encoded? How can you tell if I'm saying a statement or posing a question? How can you distinguish me from Divyansh, from Rahul, from Maggie, from all the speakers you encounter daily? And so indeed, here we have the sentence again.
Movies demand minimal energy.
And this sentence is presented as a statement. And you can see that the waveform overall is pretty flat. And so we can expose patients to a variety of these sentences said in a variety of different ways and interrogate how the different brain signatures are. And so here we have, again, the neutral sentence.
Movies demand minimal energy.
Here we have it with some emphasis.
Movies demand minimal energy.
A little bit different emphasis.
Movies demand minimal energy.
And then finally, a question.
Movies demand minimal energy.
And we have the corresponding waveforms sort of illustrated here on the right. And we can do so with the male speaker with a relatively low pitch, as well as a female speaker with a relatively high pitch. And we can interrogate how the brain interprets these things differently. And indeed, the parts of the brain that specifically responded to intonation, to speaker, as well as to sentence content were localized to these red bubbles here. If we look closer, these areas actually responded to these different features differently. So let's zoom in on E1 here. This E1 place, when we exposed the patient to sentences with different types of inflection, had very different response, whereas this E1 area did not seem to care about the content of the sentence or who the speaker was. And therefore, E1 is specifically activated to decode how the sentence is spoken, to tell us, okay, is someone's giving us a statement or asking a question. Similarly, the same kind of analysis can be done for the area E2, which cares about the content of the sentence and remains fairly agnostic to the intonation as well as the speaker identity. And the same for E3. E3 cares about who the speaker is and not so much about how the sentence is said or what words compose the sentence. What I thought was super interesting was that the way this area encodes intonation doesn't actually depend on absolute pitch, but depends on relative pitch. So as long as there is that upwards inflection, whether my voice is low, high, somewhere in the middle, or just completely wacky, it'll still be that area that decodes this information. And so all of this work was done by Dr. Eddie Zhang at UCSF, who, like many other neurosurgeons around this country, can do research because of the unique clinical scenario they have to ask some very basic questions. And so I hope this vignette really highlights how unique clinical scenarios can be a platform for performing research that could not easily be done otherwise. All right, so I see Maggie in the back tapping her watch, so I'm going to go rapid fire here. And the last 3 vignettes will simply be mini vignettes. Our first mini vignette is about fluorescence-guided surgery. And this was really, one of the pioneering centers of this is actually here at Penn with the Center for Precision Surgery. And the goal here is to improve surgical outcomes. So this is the problem that these surgeons faced. Here is a patient with a lung adenocarcinoma. We can see it very clearly on CT. Now, of course, the little red arrow helps. Once we enter the chest thoracoscopically, the question is, what do we take out? Right? And of course, it's tempting to say, oh, well, this piece of tissue looks a little funky. Let's remove all of it. And the question is, well, are you sure you're not leaving stuff behind? And indeed, 40% of cancer recurrence occurs locally after surgery. And so okay, maybe let's be conservative and take a larger piece of lung out. Well, then the question is, well, do we need to take so much out? Can we leave some behind so that the lung can do some physiology for the patient? And so luckily, this patient was infused with a fluorescent tracer. And if we turn on the near IR channel, we can see the tumor very clearly lit up, and we know exactly what to go after. And indeed, this effort has been in collaboration with numerous chemists, radiologists, industry, and many more to design fluorophores that selectively accumulate within tumors, as well as fluorophores with targeting moieties appended to them to target certain molecular features. And so all of that imaging we do in our labs can actually be brought into the operating room. Second mini vignette I'd like to talk about is extracorporeal shockwave lithotripsy. And here I really want to emphasize the opportunities to collaborate with industry and medical devices. And so these lithotriptors come in 3 different varieties. We have our electrohydraulic, electromagnetic, and piezoelectric lithotriptor. But the goal here is to deliver a focused shock wave to break apart a urinary tract stone so that it can be passed naturally by the patient without the need for surgery. The story of how this was developed is really interesting. So Dornier MedTech was actually originally an aerospace company, and they were looking at shockwave phenomenon when their space shuttles re-enter the Earth's atmosphere. And somehow a urologist was involved in that conversation. And they thought to themselves, okay, well, if the shock waves are strong enough to damage the outer layer of these, metallic ceramic space shuttles, maybe these shock waves could be strong enough so that we can deliver to the kidneys so that the kidney stones would just crumble into bits and could be passed. And indeed, that was how the cookie crumbled. And so today, urology's treatment for kidney stones is actually more than 50% based on this lithotripsy approach as opposed to the more traditional ureteroscopic or open surgical approach. Our final mini vignette today really takes a look at some of the innovation in Penn's history. And this is the development of TPN. And really, we want to emphasize here how all these failures that was encountered by this gentleman, Dr. Jonathan E. Rhodes, really pushed forward this kind of progress. And so this is indeed the Rhodes of our well-known Rhodes Pavilion. He was a resident here at Penn. He was a faculty in the Department of Surgery. He was provost of the university at large, as well as chairman of the department. I think my favorite story about Dr. Rhodes, and this is really sort of crazy to think about. So after he finished training, one of his mentors, Dr. Ravden, and indeed this is the Ravden you're thinking about, had a case of acute cholecystitis. Right? And he had the entire department to pick from who should do his gallbladder surgery. And you know who he picked? He picked Dr. Rhodes, who was just a year or two out of training. Now, of course, he wouldn't let Dr. Rhodes be there alone. He called in Dr. Alan Whipple down from New York. Yes, indeed, that is that Whipple. What was even crazier was Dr. Rhodes did not undergo general anesthesia. He underwent spinal anesthesia. In fact, was so chatty during the procedure, Dr. Whipple said, Rav, shut up or scrub in. Can you imagine operating under these conditions? Anyways, so Dr. Rhodes throughout his career was a GI surgeon, and many of his patients after GI surgery could not tolerate oral food, and this was a big problem. And so he sought to develop an IV nutrition regimen that would help these patients have the nutrition they needed to recover well. But this was certainly no easy task. There were lots of issues with finding the right formula and finding the right ways to deliver this nutrition into the patient. All of this work with him, his colleagues in the Department of Surgery, as well as biochemists, culminated in this work where he fed this beagle puppy his IV nutrition regimen. And you see that the beagle puppy in the solid line actually even grew better than the beagle puppy who was fed normally with oral foods in the dotted line. Here is one of the first patients to receive Dr. Rhodes' TPN formulation. And this was a patient with intestinal atresia. And for the first 2 months or so of life, could not tolerate any oral food and was fed exclusively with Dr. Rhodes and his colleagues' formulation. And indeed, over the 2-month period, gained about 2 kilograms in weight and grew fairly well. So I hope that with all of these 6 vignettes, we really emphasize how failures really drove the need to pursue research, whether it be basic research, clinical research, translational research, or any kind of mix thereof. We also hope to really have communicated the 3 surgeon scientist opportunities, right? The ability to come up with new surgical treatments, the unique clinical scenarios as a platform for performing research that could not easily be done otherwise, and finally the scope of practice, the idea that physicians just want to take care of the patients they see day in, day out, and these patients really drive their kind of innovation. With both motivation and opportunity, in our research and talking to numerous surgeons on the Penn community, we've identified 3 additional recipes for success. First is dedicated time to pursue research, write grants, establish collaborations, go to conferences, and all these things you need to put together a successful career. Hand in hand is decreased pressure on clinical productivity. And finally is mentorship and training, the kind of training we are getting here today as the very beginning, as well as the mentorship throughout your entire career. Unfortunately, although we thought we were really smart, this was not identified first in 2017. In fact, our very own Jomo wrote a paper about this back in 1990. And since this time, numerous schools and programs have been working towards this to really foster the next generation of surgeon scientists. All right, so the only thing left here is 3 important questions. The first question is, how do I tackle the bias against surgeon scientists? And we felt like this question was best answered with the quote given to us by Dr. Alan Flake. This quote is from Francis D. Moore. A surgical investigator is a bridge tender, channeling knowledge from biological science to the patient's bedside and back again. He traces his origin from both ends of the bridge. He is thus a bastard and is called this by everybody. Those at one end of the bridge say he is not a good enough scientist, and those at the other say he does not spend enough time in the operating room. If only he is willing to live with this abuse, he can continue to do his job effectively. There's not much more I can say beyond that. The second question of 3 we ask is, what if things aren't working out? Right? And this quote we felt like best addressed this. And this was from Dr. Steve Zedrick. And he quotes Eugene Kleiner, make sure the dog wants to eat the chow. And from this, we took 2 lessons. First, maybe you need better chow. Maybe you need a better idea. You need to find a different research direction. But on the other hand, make sure you find a hungry dog. Make sure you find a place that was willing to support you, as well as a time that is ready to accept the kind of innovation you're proposing. And finally, we come to our third question. And this is the last thing we'll leave with you, so you know it's really important. And the third question here is, who's next? So certainly we'd like to acknowledge everybody in our MSTP family, especially Rahul for all of his comments, to the many more who helped us prepare this presentation, and countless others who have mentored us along the way.